Hello everyone, and welcome to today's webinar. My name is Emma Broom, and I'll be your moderator and speaker during the session. While I'm a proud ambassador for FH Europe, I also represent my national patient organisation in Britain, which is Heart UK. The topic of today's webinar is understanding elevated Lp(a), another inherited cardiovascular risk factor. I'm very pleased and honoured to be joined by two international experts, Dr. Jamini Segler, a consultant in metabolic medicine at Imperial College London in the UK, and Professor Florian Kronenberg, head of the Institute of Genetic Epidemiology at the Medical University of Innsbruck. Together, we will help you understand more about what Lp(a) is, and why the high levels of Lp(a) are dangerous to our cardiovascular health. This webinar takes place just 2 days before the World Stroke Day on October 29th. And while we'll explain the connection between Lp(a) and stroke, we will not focus too much on the stroke. However, we'll invite you to check out our available materials and our patient educational information related to stroke prepared on this occasion by partners like the European Stroke Organisation and SAFE, the Stroke Patient Organisation. For those of you joining us for the first time, FH Europe is a network of patients' organisations across wider Europe. There are 29 organisations in the network. As an international community, we're committed to advocating for and supporting people living with inherited dyslipidemias like FH, HoFH, elevated Lp(a), and FCS. This session is aimed at raising awareness and increasing health literacy among our patients internationally, the general public, and as well as developing our patient ambassadors. Today's webinar is the third one out of 4 sessions under the umbrella of FH Europe Ambassadors Training and is organised in partnership with the European Atherosclerosis Society. The previous 2 webinars covered the topics of FH paediatric screening and understanding your lab results. The final one, which has been rescheduled, is dedicated to FCS, familial chylomicronemia syndrome, which is another rare and serious lipid condition. We'll be putting out more information in the near future as to when that's been rescheduled for. So now we would love to know a little bit more about our audience. So please write in the chat where you are, where you are joining from, and what you hope to learn today. We're delighted to have so many of you join in FH Europe's events regularly, and we're always happy to discover new participants. While you do that, I'd just like to share a little bit of housekeeping. The webinar is being recorded, and it will be available on demand on FH Europe's YouTube channel, where you can also watch it with subtitles in your local language. It's also streamed on Facebook. If you have any questions, please don't hesitate to post them in the Q&A section or on our Facebook stream. We'll try to answer as many of them as we can live in the same Q&A section. Please avoid any specific questions related to anyone's personal health records or treatment. Okay, so let's start. I'd like to hand over to Dr. Segler, who will explain to us exactly what Lp(a) is and its role, and what an excess of Lp(a) can cause. We wish to make sure everyone listening knows the Lp(a) numbers and how to prevent how prevalent this genetic condition is. Some of you may already recognise me from the past webinar dedicated to understanding your lab results. Today, we'd like to dig a little bit deeper, and I guess my personal story is relevant, as I have both Lp(a) and FH. As somebody said to me, I've hit the jackpot having both. Now, people with FH do tend to have higher elevated levels of Lp(a), but it's not necessarily common. So if you find that you have both, you don't stress about it. Don't worry. It's not something to be overly concerned about. It can still be managed, as I'm sure Dr. Segler and Professor Kronenberg will go on to tell you in just a moment. So Dr. Segler, I'll hand over to you.
Thank you so much, Emma, for that great introduction. As Emma said, my name's Jay Segler, and I'm a physician. I work in London at the Hammersmith Hospital, and I look after the lipid service there. And as well as that, I also do some research. So we do research in Lp(a) as a risk factor for heart disease, and also we're looking at some current new treatments, hopefully on the horizon for lipoprotein(a). So that's where I work, here on the left at the Hammersmith Hospital. And today I'm going to spend the next 10-15 minutes just giving you the basics of Lp(a), and then after that, Professor Kronenberg is going to go into some more details. So next slide, please, Shveta. So these are just my disclosures. So I have received, I advised to several companies, and as well as that, I've had some research fundings from some of these companies here. And I'm also a member of the Medical, Scientific and Research Committee for Heart UK, which is our cholesterol charity within the UK. Next slide. So let's talk about Lp(a) or lipoprotein(a), and it is a bit of a mouthful, and we shorten it often to Lp(a). So lipoproteins, what does this mean? You may have come across the term lipoprotein before, and the way I like to think of them are vehicles for transporting our cholesterol and other blood fats around the body. And the other famous lipoproteins that you might have heard of are HDL, sometimes known as the one that carries the good cholesterol, and very famously the LDL as well, which is often thought about as carrying the bad cholesterol. And then we've got Lp(a) or lipoprotein(a), and like LDL, it looks very similar. It's this yellow blob full of cholesterol, and wrapped around it like a ribbon, it's got this blue ribbon here called ApoB. So it looks very much like LDL cholesterol, and you'll be familiar with LDL cholesterol from your blood reports. But what's different about Lp(a) is that it's got this other sort of ribbon wrapped around it, which we call apo(a). And I often think of this as a bit of sort of almost like Velcro that's stuck to the lipoprotein. And part of this makes the Lp(a) a little bit more, making the blood a little bit more prone to being sticky. Next slide, please. So let's look at the distribution of Lp(a) in the population. So the first thing you'll notice, we've got men on the left, women on the right, and those distributions look pretty similar. So the distribution seems quite similar between men and women. And on the x-axis, if we just hone in onto the men, you can see the concentration of Lp(a). And the more we go to the right, the higher the concentration gets. And on the y-axis, we've got the fraction of the population. So you can see that in green, the vast majority of the population have pretty low levels of Lp(a). And we've sort of split this into half. So above 50, it goes red. And you can see that's where 20% of the population lies. And actually, the 50, we've done this as the sort of traffic light system here. But as you can see, it's a spectrum. There's lots of people who've got below, but there's about 20% who have above. And the other thing to notice here is that there's two different units that are used. And this is really, really important when it comes to knowing your numbers, because some countries will report in milligrams per deciliter, some will report in nanomoles per litre, and in fact, in some countries, it's reported in milligrams per litre. And even within countries, different labs will report with different units. So it's really, really, really important to make sure that you know what unit your report is reported in, because that will really tell you where you sit along this graph. Next slide, please. So we talked a little bit about the distribution of Lp(a), but why do we care about it? What makes this so important? And the main reason is that because of the nature of this lipoprotein, it appears to increase our risk of certain conditions. And I've got 4 graphs here. So sorry, it's the evening and we've got graphs, but I'm going to try and go through these in a straightforward way. And the one I'd really like you to focus on first is this one on the top left which says myocardial infarction. So myocardial infarction is just a posh word for heart attack, okay? And again, if we look at the x-axis tells us that we're getting increasing levels of Lp(a). And on the y-axis, we're seeing risk, okay? So the risk of heart attack. And you can see that as the Lp(a) level goes up, the risk of heart attack also goes up, okay? And so it's not a binary thing that, having levels over a certain, the higher the level, the higher the risk. It's not that if the level goes over 50, then your risk is high versus low. It's a spectrum and it goes up dependent on the concentration. And you can see the same sort of pattern when we look at heart failure. So what we mean by that is the pumping of the heart. And the ability for the heart to pump effectively. And then also at the bottom here, aortic valve stenosis, which is narrowing of the aortic valve, one of the main valves of the heart. And then lastly, up at the top right graph, you've got one for ischemic stroke. And what we mean here is that stroke that is caused by blockages of the arteries supplying the brain. But what you can see here is that relationship is much more shallow. If you compare it to the one for myocardial infarction, you can see that that red line is not so steep, but there is still a relationship there. And this is, as Emma said, particularly pertinent with World Stroke Day coming up in a couple of days. Next slide, please. So hopefully that gives you an idea about the relationship between Lp(a) levels and the risk for certain conditions. And why do we think this is? Why does Lp(a) cause this risk? And there are 3 main things that we're currently thinking about in our current understanding of Lp(a). There are 3 factors that appear to make Lp(a) more likely to be a risk factor. And the first is this, what we call proatherogenic, which means we think that Lp(a) leads to furring of the arteries. And the way we think this happens is that because it looks very similar to LDL cholesterol, it manages to get into the arterial wall and enable that clogging and start some of that narrowing process. The second thing is that it appears to be pro-inflammatory. And what I mean by this is that once it gets into the arterial wall, it can increase it can sort of make the arterial wall angry and let out sort of a cascade of inflammatory markers. And then the last thing, which is a little bit smaller print, is what we call prothrombotic, so pro-clotting. And this has been borne out in experiments that have been done in things like in test tubes and Petri dishes, but not so clear when we've actually done human studies. But we think that because of this apo(a), this second ribbon that runs around Lp(a), it appears to make the blood a little bit more sticky than it would otherwise be. Next slide, please. So how common is Lp(a)? And as you can see, I mean, when we looked at those distribution graphs, we said that 20% had those higher levels where the risk starts to become increased. And if we take that level of greater than 50 milligrams per deciliter, one could calculate that 1.43 billion people around the world are estimated to have high Lp(a). That's a lot of people. And the other thing I just want you to appreciate from this slide is that we know that the concentration of Lp(a) differs between ethnic groups. So we know that African people tend to have higher Lp(a) levels, and people of Chinese origin tend to have lower levels. So it does vary depending on where you're from. Next slide, please. And finally, I just wanted to talk a little bit about LP(a) and genetics. And you probably heard that you're born with your LP(a) levels, and we think about 90% of it is genetically predetermined. And these levels, so you're born with them, they go up a little bit, and then by the age of 5, they tend to sort of steady out. So, for example, if you have, if mum has high LP(a) levels and dad has pretty low levels, your levels will be the sum of both mum and dad. So it takes the average of both your parents, rather than being like with some of our other conditions that we think about in lipids, for example, FH, you have a 50% chance of getting the gene from either mum and dad. For LP(a), it's a combination of both the genes from mum and dad in total. I'm going to leave it there, Emma, and I think I'm going to pass back to you, and more than happy to take questions as the webinar carries on. Thank you very much.
Brilliant, Jay, thank you so much. That was super informative, and particularly from my perspective as a person with LP(a), your slides were informative, but also really easy to understand as well. And I really appreciate that from a patient perspective. And as well to know that there's 1.43 billion people worldwide that have that. That's absolutely phenomenal. And the amount, I had no idea that it was that common. And in some ways, that's actually quite reassuring to know that so many people do actually have it. Speaking from my own experience, there's a lot of doctors and sort of family GPs that aren't that familiar with LP(a), and I find myself going in and having to educate them. Obviously, being a GP, it's not their responsibility. They can't know absolutely everything. But yeah, it's interesting and reassuring to know.
I think you're right, Emma. I mean, it's getting the balance right, isn't it? Because, on the one hand, we need to increase awareness of this important risk factor. But at the other side, we need to accept that, it is one risk factor. And there are lots of risk factors for coronary disease and stroke as well. And, for example, obesity, smoking, blood pressure, all of these other things are very, very important too. So it's putting it into context that's important.
Yeah, absolutely. And I thought your slides did that brilliantly. And the other thing I learned as well is I didn't realise that your LPA number is taken from both parents. I assumed it was inherited from one side or the other, and there's a 50% chance of it being passed on. I had no idea that there is a combination. So that was really interesting as well. Thank you.
Pleasure.
Great. So shortly I'll introduce Professor Kronenberg to the stage, or virtual stage. But if it's okay with everyone, I'll just give you a little bit of an insight into my life and how I discovered I had LP(a) and also FH. So 9 years ago, back when I was 33, or 9.5 years ago, my mother tragically passed away from a heart attack. She was 66 and super slim, fit and healthy, as were both my parents. And so it came as a complete and utter shock when she passed away so tragically and unexpectedly. When I was younger, when I was 11, my dad had been told he had high cholesterol. So we automatically, as was the case then, we went on a low-fat diet as a family. So, through my childhood, I've always eaten really healthily. Dad managed to control his cholesterol levels through diets and never had to have statins. And my mum's cholesterol levels were always fine. They were, I suppose nowadays you probably say it was slightly high, around about 5.4, but at the time, it wasn't considered high enough to take action. Sorry, 5.4 is a ratio of HDL and LDL that we use in the UK. The measurement is, I think it's milliliters per litre or something, milligrams per litre, I think. I'm sure Dr. Segler or Professor Kronenberg can correct me there. So that was a complete shock. The family doctor took me in, tested me for cholesterol. My ratio was 8.4, so certainly high, and I got put on statins straight away. Interestingly, prior to that, when I was 23, so a good 10 years before, I'd had an Italian boyfriend whose dad was a doctor, and he tested me for cholesterol, and he put me on the diet straight away. And I went back to the UK, and I told my doctor at the time, and he said, "Oh, you're female, so your estrogen levels will protect you from cholesterol." So I didn't do anything about it, and it was only with my mother passing away that I went on to statins. And at that point, I was quite I didn't feel it necessary to have genetic testing for FH, which was offered. As part of my job, I work as a yacht chef, and I was due to do a circumnavigation, and my doctor at the time said, "Wouldn't it be lovely if you didn't have to go and collect statins partway around the world?" So in my eyes, she kind of bribed me slightly to go and have a test. And I was under the hospital in Bath, and the professor there was amazing, and little to my knowledge, he tested me for Lp(a) as well. And both results, Lp(a) tested positive with high elevated levels, and also FH. So instead of thinking I was being tested for one, I was tested for two, and ended up with both of them. So definitely the jackpot. And Dr. Segler is absolutely right. Lp(a) in my eyes is the Velcro that sticks the LDL to your arteries. So I now take statins and ezetimibe, which I recognise is more orientated, of course, to BFH. But I'm hoping I'm an example of somebody that can, continue to live their life as they wish. I was very scared, I'll be honest, when I first got diagnosed, because I didn't understand what it meant with regards to VFH and the Lp(a). When your mother's just passed away from a heart attack, and you've been diagnosed with potentially what it was that caused that heart attack. All of your movements, like I've always been a big runner and a cyclist, and I do adult gymnastics. For a year, I almost put everything on hold just because I was scared. But then with the support from the doctors I was with, the FH and the Lp(a) nurse, and also Heart UK as well, which, as I said, was our UK heart charity. I realised it wasn't something to be scared of, and I'm now proud to say that I continue with my life, and I live it how I want to live it, which is doing crazy things like adult gymnastics at 43, and I do work as a yacht chef on super yachts, and I don't let my conditions influence me too much. Obviously, I go see my cardiologist regularly, and I have regular checkups. So hopefully, if anyone watching this now or in the future does have Lp(a) or FH, don't let it scare you. It's something that can be managed, and there's new treatments coming out all of the time, which I believe Professor Kronenberg will dip into as well. I do consider myself lucky. I've known now for 9.5 years that I have this. I know how to manage it. There's fantastic support out there. So, Professor Kronenberg, I'd love to hear a little bit more about your work, your findings, and the recent international consensus published in August when it comes to Lp(a) and the testing. How can we estimate the risks, and more importantly, help us all understand what we can do in the absence of approved treatment? Otherwise, it would be very unethical to suggest we test for a condition when nothing can be done. I'm absolutely delighted to be joined with you, and the virtual stage is yours.
Thank you very much, Emma, for this nice introduction. And I think you gave us a very interesting testimony how it is when you have high LPLA concentration and high LDL cholesterol concentration. And I think you gave us already a very important message that you have to go on with life and enjoy the life. This is also very important, but be careful and watch your health and go to the cardiologist and all this stuff. And then in case something develops in terms of atherosclerosis, then you can act much earlier without compared to the situation without knowing it. Can you see my screen now? Hello?
Yes, we can see your
Yes, we
slides.
see it.
Okay, wonderful.
Yeah,
so I had the great pleasure, together with Samir Mora from Harvard and Eric Struss from Netherlands, to chair this consensus paper. And we worked very hard on that over the last year. And 2 months ago, we presented at the European Cardiology meeting. And first of all, I would like to tell the audience what is a consensus paper? So what is it good for? It is important to bring the knowledge of independent experts on LPA together in one document. And we have, and this is the important part, we have to find the lowest common denominator that everybody can agree on. This is very important. And it is kind of a collection of evidence we can trust, and it's not based on an opinion of a single expert, because there's a difference whether I, as Florian Cronenberg, tells something or whether a group of 22 other people is agreeing on that. And if I have a certain opinion, I have to convince the other experts, otherwise they will not agree on that, and it will not be put into this consensus paper. So this was really interesting observation, and you can use this consensus paper as a kind of advocacy for LPLA, and use it then finally to convince politicians that it is really important to measure LPLA, and when we have treatment that we have also to treat it. So overall, it was relatively easy to come to a consensus. I can tell you, I was a little bit in fear when I took over the chair for this, whether we can really find a consensus. But it was really fun to work with those people and also to find this consensus. So first, short introduction of how often do we find these high elevated concentrations. So in 70% of the population, we have relatively low concentrations up to 30 milligram per deciliter, or the other unit 75 nanomoles per liter. And the risk for cardiovascular disease like heart attacks and stroke is not elevated. But we have also the other 10% of the population who have concentration between 30 and 50 milligram per deciliter, which transfers to 75 to 125 nanomoles per liter. And the risk is increased by 30 to 40%. But then we have this 20% of the population who have the LPLA concentrations above 50 milligram per deciliter, and the risk is increasing 50 to 200%. And we can clearly say the higher the concentrations, the higher is the risk. And this is really important to know. So there's not really a very strict threshold, but we can say the higher the concentration, the higher is the risk. So for what outcomes, for what clinical endpoints, we call it, do we have knowledge that high LPLA is associated to? We know already quite long that high LPLA concentrations is related to heart attacks. We call this also myocardial infarction. But roughly 10 years ago, a huge number of papers were published which showed that high LPLA is also correlated to aortic valve narrowing, and also to stroke, which is important because we have in 2 days, we have the World Stroke Day on October 29. And there's also an association between peripheral arterial disease. And interestingly, both situations are quite common. High LPLA, roughly 20% of the population, and these cardiovascular outcomes. We have to keep in mind that roughly 35% of the people in Europe are dying still from cardiovascular disease. This is the number one killer, we can say. So therefore, it's important to figure out where are the risk factors and to know about them. So why do we know that Lp(a) is causally related to heart attacks? This was a big discussion 25, 30 years ago. So the genetics paved the way for our understanding on causality. We know that there are Lp(a) increasing genetic variants. We have already heard from Jay that this is inherited to the next generation. So we have those genetic variants which are associated with lifelong exposure to high Lp(a) concentrations. Those variants are also associated with increased risk for cardiovascular disease, for heart attacks and stroke. And if we can make this triangle in that way, then we can get really strong support for causality. So, but is there then finally a need for genetic testing? No, we have not to test genetically for high Lp(a). We can simply measure it in the blood. So by definition, it's not really a genetic testing. We're making simply a biochemical test in the lab where we measure the Lp(a) concentration in blood. This is completely sufficient. So what did the consensus panel recommend on Lp(a) testing? We said Lp(a) should be measured at least once in all adults to identify those with high cardiovascular risk. A very clear recommendation, which is in line with other guidelines, for example, from the European Society of Cardiology and also for the Canadian Cardiovascular Society. So there's a very clear recommendation. We give also in the consensus paper screening recommendations for young people when they have, for example, very rare cases of a history of stroke, or when there's a family history for high Lp(a) heart attacks without other known risk factors. We give also recommendations for family cascade screening for high Lp(a) in case of familial high cholesterol levels, or a family history of very high Lp(a), or a family history of cardiovascular disease like myocardial infarction and stroke. So some points on testing. How often should we test? Since it's very strictly genetically regulated how high the Lp(a) concentration is, and genetics does not change during life, it's usually enough to measure it once in a lifetime. In most of the cases, there are some exceptions, but it's not important for now. So is testing already in place in various countries? Yes, the testing systems are available, but testing is not very common. There are still hospitals which are not testing for Lp(a) concentrations. And it can be done together with all other blood tests. For example, the best idea would be to do it during the first lipid profile testing, for example. So we try at the moment to convince physicians and GPs to test more often. And I think education is very important, but also you as a patient or as an individual can put up the pressure by pointing physicians and GPs to the consensus paper or to the very nice Lp(a) brochure from FH Europe, for example. So that try to convince them that it's really important. And I hope during this presentation that I can convince you that it's really important to measure it. The costs are not so high, between 5 and 20 euros. Consider what a test costs for COVID-19. And the prices should drop when it becomes to a routine test. And in some countries, it's even covered by health insurance. For example, in Austria, it's absolutely no problem to get it at least measured once, and the health insurance will pay for it. So how can we incorporate now then, when we get the test result back, how can we incorporate the Lp(a) measurement in risk estimation? I show you here a slide. It looks a little bit complicated, but I will guide through very slowly through it and explain what it means. So here on this y-axis, we call it, there's the calculated lifetime risk for a heart attack and a stroke. And on the x-axis here, we can see the baseline risk categories, which are coming from the traditional risk factors. And these traditional risk factors are age, sex, blood cholesterol, blood pressure, smoking, diabetes, family history of heart attacks in early life, and body mass index. And for each of you, we can calculate, based on those traditional risk factors, kind of a baseline risk category from 5 to 25%. If someone has a lot of those risk factors, of course, this baseline risk category is much higher, let's say 25%. And these forefront bars are from those people who have very low concentrations of Lp(a). And in behind, we see the risk calculated for the different Lp(a) concentration categories. So then, on each end of those bars here, there's a percentage number. And in this case, it says us a person who has a baseline risk of 25%, so that means a lot of traditional risk factors, and an Lp(a) concentration of 150 milligram per deciliter or 350 nanomoles per liter, this Lp(a) concentrations adds further 43% in risk. So this is a tremendous increase in such a situation. Let's make an example here. Let's assume we have people here with 50 milligram per deciliter of Lp(a), roughly 115 nanomoles per liter. And we have a person who has very low number of risk factors. So the baseline risk is only 5%. Then the risk by this 50 milligram per deciliter is increasing to 7%. If a person has a baseline risk of 25%, so meaning a lot of risk factors, the additional 50 milligram per deciliter of Lp(a) increases the risk to 35%. Let's assume and this is a 1.4-fold risk increase. Let's assume we have persons with 150 milligram per deciliter of Lp(a), so meaning very high Lp(a) concentration, and the baseline risk from traditional risk factors of 5%. This is increasing to 14% by this high Lp(a). And as I mentioned already before, the one with the very large number of other risk factors, the risk is increasing from 25 to 68%. So this is really a tremendous increase. Overall, we can say a 2.7-fold risk increase. So if we do not measure Lp(a), the absolute risk might be underestimated tremendously. So in this case here, 25% without Lp(a) measuring, but 68% when we consider these very high Lp(a) concentrations. So why does not everyone with high Lp(a) concentrations get a heart attack? This is an often asked question, and there are a couple of explanations for that. Let's assume we have here persons who have a very low number of risk factors. They have only a risk of 5%, and if that person has 150 milligram per deciliter from Lp(a), so the risk is increasing to 14%. Please consider that 35% of the average population in Europe is dying from heart attacks. So this person has a relatively low risk despite Lp(a) is relatively high. Or the other explanation is that the person might be genetically protected against heart attacks. So that means that person has a lot of many good genes, which are protecting that person to develop a heart attack. Also, high Lp(a) concentrations are available. So an isolated Lp(a) concentration is not a guarantee that someone really gets a heart attack. The same is true for smoking. Not everybody who smokes gets lung cancer, but nevertheless, you should stop smoking anyway. So what to do now in case of high Lp(a) concentrations? Don't get nervous. You are not alone. There are a lot of people out there who have this high Lp(a) concentration. And in the consensus paper, we made the following recommendation. Early and optimal management of traditional risk factors is recommended for those people who have the high Lp(a) concentrations. In some countries, lipid apheresis is also a possibility, especially in patients with very high Lp(a) and progressive cardiovascular disease. So that means they had already a couple of heart attacks or something like that. Then there might be a possibility to make lipoprotein apheresis. We provided also a table in the consensus paper, which shows us, on the one hand, the risk factors, traditional risk factors. On the left side here, when we go from top to bottom, we can see a risk increase by these traditional risk factors. And from the left to the right, we can see increasing Lp(a) concentrations. And depending on the combination, we can recommend different things. So if you have a low risk from other risk factors and also low Lp(a) concentration, There's only the lifestyle advice. But if the risk is increasing by the traditional risk factors and at the same time the LPLA concentrations, therefore more strict lifestyle interventions necessary, including also drug treatment for LDL lowering, blood pressure lowering, glucose lowering, and so on. And for more we go to the red area here, we have to be quite strict to fight against the risk which is coming from both sides, from the traditional risk factors as well as from LPLA. So why is it important to start early with treatment before the first symptoms of cardiovascular disease are present? So the simple rule is don't wait till something happens, because in many cases, the first event can be deadly, and you would like to avoid that. Therefore, you would like to start to treat, for example, risk factors which you can treat. If someone has a high LDL cholesterol, you would like to lower it, and you would like to start already at the age of 30 and not at the age of 60. If you start at the age of 60, you need twice the LDL lowering, and therefore more medications and stronger medications as you would like to, compared to the situation where you start the treatment already with the age of 30. This is very clear because the vessel walls had then already been exposed to elevated cholesterol for 30 years longer, and the damage caused by that is no longer stoppable or reversible. So this is also true for other risk factors. So knowing the risk is very important, because this can be really a strong input to stop smoking, for example, to change the lifestyle, to lower the blood pressure and the high glucose levels. So starting prevention early is really a very, very important key. But let me come back again to those people who have the very, very high LPLA concentrations and also a lot of other risk factors. So the main part in this situation is coming here from LPLA. And of course, management of the traditional risk factors will be important, but it will not be enough. And for those people, we are eagerly awaiting the specific LPLA lowering therapies. And these therapies are on the way, we can say. There are some specific LPLA lowering therapies which are targeting LPLA concentrations, and they have in common, all three of them here, which are listed here, are able to lower LPLA concentration by about 80%. And one of those medications is already in the last testing phase, and we expect the final clinical study results by the year of 2025. So there are really interesting times in front of us, and we are really eagerly awaiting the results. So why should I measure LPLA now when I cannot yet lower it? And this is an often raised argument by even by medical doctors. And I always like to bring this slide here and this study here, because this very impressively shows that acting already now is very important. This is a study where they observed people for more than 11 years, and then they classified people depending on their risk factors which can be influenced: smoking, overweight, diabetes, hypertension, high cholesterol, physical inactivity, unhealthy diet. And then they group the people depending on the number of those risk factors. And they had the one group which had an unhealthy lifestyle with a lot of those risk factors mentioned above. They used this group as a reference group for comparison. And then they had a middle risk factor group and a healthy group who had only no or only one or two risk factors. And then they looked who developed over these 11.5 years in heart attack. And they could really see that those who had an intermediate risk factor profile and those who had a very high healthy risk factor profile, they had 1/3 and 2/3 lower risk to develop a heart attack over time. So this is a very important message for our patients to show them, even if you have, and all of them in these groups had the same average LPLA concentration. And the message is very important to those patients. If they have still risk factors which they can address, they should really work on that. And I think one of the most important points is please stop smoking, because this can really lower your risk. And if you have high LDL, lower it very dramatically, and also the blood pressure. So why should I measure now Lp(a) when I cannot yet lower it? Please tell the doctor the next time when he says, no, I would like to measure Lp(a) in your case. It is a causal risk factor. It's a very frequent risk factor, as we heard today. It is helpful for risk estimation to get knowing the risk you are exposed to. And I can already act now, as I showed with the last slides, because fighting the risk factors you have is very important. And therefore, my message is measuring Lp(a), do it without ifs and buts, and use it then finally for your daily risk estimation and also acting on your other risk factors which can be influenced. Thank you very much for your attention. I'm looking forward to your questions now.
Professor Kronenberg, thank you so much for such an informative presentation. I loved your slides. They were very, very clear, and particularly the traffic light system with the red, the amber, and the green. Again, from a patient perspective, it was super helpful, and also taking into account how important the other lifestyle factors are as well, such as not smoking, exercising, eating healthily too. I mean, I must admit, I'm fortunate, I'm slim and I enjoy exercising, but like the majority of people, I do like cake, I do like pastries and chocolate. So it's trying to do that in moderation as well, and being mindful all the time of just generally how we live.
I want to add one point. I think it is extremely important never to look at the single risk factor alone. Put it also in the context with the other risk factors. Try to get the global picture of a person, and then you can try to develop a plan, what you can do. If you are really have the situation that you have, as you, high LDL and also high Lp(a), this should convince you, and I think you are already convinced, that you can do something about this and not wait till the first heart attack arrives. I think that would be nonsense. You have to act now.
Yeah, absolutely. I think it's being aware, putting everything in context as well, and as you said, not treating lipoprotein (a) as an isolated factor. And also, it's great to know that although, at the moment we're using statins to lower the LDL, as Jay said, and that can really help with the Lp(a), it's good to know that there are future treatments that are going to be available in the forthcoming years. That's really positive. So thank you both. In the last 10 minutes or so, I just wanted to have a little bit more of a discussion and ask you some questions, if that's okay. Jay, based on your daily practice and seeing people with Lp(a), what are the biggest concerns or areas where we as the ambassadors and patient groups could help you? Also, is it something that doctors report on in other countries as well?
Yeah, I think the biggest challenge is lack of awareness around the risk factor. So I have patients who've been to several physicians, several GPs, etc., and cardiologists as well, and they've read about Lp(a), but unfortunately their physicians aren't as well educated about them. I mean, certainly when I went to medical school 20 years ago, I hadn't heard about Lp(a). It wasn't something that we were taught about in the undergraduate curriculum. So I think as physicians, Florian and I in the field, we have a responsibility to educate our peers. But I think, patient groups have a huge role to play in raising the awareness of these risk factors.
Mm. That's great to know, and I think you're right. Even as patients, sometimes we could think, well, what can we do? But with the support of yourselves and charities such as FH Europe and all the country charities as well, we can go into our local doctors' surgeries, we can go into hospitals, we can leave information and just help to increase that awareness for both the health professionals and also other patients as well. So just another question. If testing for Lp(a) isn't done routinely, can you suggest who should ask for it and how? So I mean, I know if I didn't know I had it already, I couldn't walk into my local surgery and say, hi, can I be tested for Lp(a) if my mother had passed away. And even then, it was only because I was under a cardiologist who was familiar with it and just automatically tested me for it. So I was very lucky, and I'm incredibly grateful to that person that did that for me.
Yeah, but Emma, I think this is really a typical case. Now you can easily say, look at this consensus paper here. It's written, every adult person should get a test on Lp(a). Mm-hmm. Of course, it's voluntarily. This is very clear. But if you demand it, a doctor should not deny it.
Yeah, that's.
I don't know, Jay, how you feel about that. Because in UK, there's a little bit different as in some other countries in Europe.
Yeah, I think, I mean, the European consensus statement is very powerful, and, makes a very, very strong statement about everyone having the right to have their levels checked at least once in a lifetime. In the UK, we did have a consensus statement that was published a few years ago, and we felt that at that stage, knowing where we are in the UK with Lp(a), we really wanted to concentrate on those people who might benefit most from knowledge of their level. And so, those would be people who have, say, premature heart disease in their family, people with FH, those who know that, other people in their family have very high levels, etc. But yeah, I think certainly the end goal would be for everyone to be tested, for sure.
Yeah,
I think the argumentation is now, and meanwhile, a little bit easier after the COVID pandemic, because everybody was tested maybe 3 times a week with a test which cost at least so much as an Lp(a) testing, and there you have to do it only once. So we should not really discuss about the costs anymore.
No, I think a lot of. Sorry, go ahead.
Sorry, I think what would be, as the evidence kind of accumulates around Lp(a), and it certainly is happening, but once it becomes something that is involved in in the risk calculators that, for example, general practitioners use in their daily practice to work out someone's risk of heart disease, I think once it becomes something that is part of sort of national guidance and things, then I think it becomes much more embedded into normal practice. Yeah.
May I add here something? Because you mentioned risk calculators. Many doctors are not using those risk calculators. But the nice thing in the consensus paper now is that it includes a risk calculator which considers also Lp(a). And it is drawing a line where it shows you the risk without considering Lp(a) concentration. And then it shows also a line when Lp(a) is measured. What is the risk, how the risk is changing? When you have very high Lp(a) concentration, risk is going up. And also the nice thing is then you can put in what happens if you from now on during the rest of your life you are lowering LDL by a certain amount, and also your blood pressure by a certain amount in case it is increased, how this changes your risk. And this was so impressive for me when Brian Ferencz showed me this the first time. I was so surprised to see that. And this can be really used then finally in counseling patients. And I think one of the big issues is counseling of patients, because this takes always time. And each week I have several conversations with patients, and they want to have it explained how this works, how is it in context with the other risk factors. It takes time. This is very clear, but it's very important.
It is. It's super important. And just out of curiosity, and I appreciate this isn't available in all countries, but do we need to have to discover if somebody has got Lp(a), is it important to have the genetic testing as confirmation?
No. So I hope I made it clear in my talk. I think from some of the questions, maybe it wasn't as clear as it could have been. But, the genetics are, it's predominantly genetically inherited, but the end biomarker, knowing the concentration in the blood, basically tells you about pretty much all the genetic risk. It's much cheaper to do the biochemistry test. I mean, in our lab, it's like £14. So, it's actually, you don't need the genetic confirmation. And also the genetics, it's lots and lots of little genetic changes together that you look at to kind of come up with an answer. Whereas actually what you want to know is what's the concentration.
Yeah, that's reassuring, because not everyone will have access to genetic testing. So knowing that it can just be done by a simple blood test sent off to the appropriate laboratory, and you can determine it, through the results. That's also good. And then specific action can be taken, whether it's just lifestyle management or the support of statins as well, can help. Florian, what about the systematic issues and solutions for people with Lp(a), building on your experience with the consensus paper? What should we be aiming for?
Yeah, I think first of all, education. I think it's very important, and Jay mentioned it very nicely. She was in med school 20 years ago. I was in med school more than 30 years ago. And we both did not learn anything about Lp(a). In the meanwhile, the students in the med school in Innsbruck, the first semester, they get already get something to know about Lp(a) because I'm teaching them. But I think that's the very important thing. We have to educate people not only in the med school. We have also to go out to the medical doctors who are already in practice, and that's the reason why I'm currently making so many presentations on Lp(a), because we have to educate people. And as soon as people, as medical doctors, start to measure Lp(a), and as soon as they make the experience, this typical experience of a person who is absolutely healthy and out of the blue, a heart attack occurs, no risk factor was available, and there was a high Lp(a) concentration. From that time on, they start to measure Lp(a) in their patients. And I think we have to bring it out to the doctors that they are really measuring Lp(a) and consider it together always with the other risk factors. This is one of the big challenges we are facing at the moment.
Mm. So it's a slow process, it's a long process, it's challenging, but we will get there, and it's education all around for potatoes, patients, and healthcare professionals as well. Brilliant. Well, we still have a few minutes left. Florian and Jay, were there any questions in the Q&A which were particularly relevant or interesting that you'd like to share verbally as well, in case people haven't dipped into the Q&A section?
Yeah, Emma, there's one question that's come up a couple of times, and I hear this quite often, and this is the worry that a lot of people have about statins increasing Lp(a) levels. And there have been some studies looking at, the effect of statins on the Lp(a) concentration, and found that, there is a slight, very modest increase in Lp(a) levels. But in terms of what we can do to mitigate or reduce the cardiovascular risk of Lp(a), the best thing that we can do is, healthy lifestyle and lower LDL cholesterol. So in terms of what you can do, and, in terms of what if you were to take medication to improve your Lp(a), the statin the benefit of it by reducing the LDL far outweighs any risk of slight increase in Lp(a).
Good. That's
I think
yeah. No, I was just going to say that's really
that's
helpful.
a very important question.
Yeah.
Excuse me.
No, I was just saying, please go ahead.
Yeah. So I think this was a very important point, and this is coming over and over again. So the message is, don't stop statins since you have a slight increase of Lp(a). I think there was another point which is often coming up, treating high Lp(a) with niacin. And I think in most of the countries in Europe, niacin is no longer on the market. Some colleagues in the US still use it to lower Lp(a). but some of the trials did not show a benefit, but those trials were not designed to treat patients with very high Lp(a) concentrations. So we do not really know it exactly. But anyway, at least in Europe, in most of the countries, niacin is no longer on the market.
Good. Right. We've been exactly an hour now, and I don't want to keep anyone longer than necessary. So I'd like to thank you both, Dr. Segler and Professor Cronenberg, for your very informative and engaging presentations. I'd also like to thank the audience for being so engaged and active in the chat and in the Q&A section as well. Before we finish, I'd just like to invite you, as I said, to the FCS webinar, which will be rescheduled with a new date in the near future, but also to visit our YouTube channel so you can watch previous sessions that we've run. And please share them with your family and your friends and patient organisations, and for the clinicians who are with us. Please use these materials to educate and support your patients you see in your daily practice. And I know the team, Magda and Spella, have been posting in the chat box with links to the FHU website and a brochure that's specifically for Lp(a). So there's so much information about that will support you. So I'd just like to thank everyone once again for joining us, and we hope you found it interesting and informative.
Thank you. Bye-bye.
Thank you. Bye-bye.